Hey, it's Dr. Hervey here. Good evening. By the way, I didn't tell you, I'm both doubly trained in family medicine and OBGYN. Never did my boards for family medicine. Worked on some ERs for a little bit, but I knew I didn't want to practice that. And I went on to complete my boards in OBGYN, but did complete the complete residency in family medicine. And in family medicine, they have a course called the ALSO course. And it's like Advanced Life Support for Obstetrics or something of that nature is the acronym for it. And so every year we'd have to renew our certification in ALSO. Anyhow, with that stated, I want to talk to you about something that I didn't learn in OB residency, but I did learn in my family medicine residency. One of the things that they talked about in that course was the 3 P's required for a vaginal delivery. The 3 P's are power, pelvis, the passenger, right? And so many times I'm counseling a patient and she's in labor and going through the throes of attempting to have that vaginal delivery. I do a lot of VBACs, and unfortunately sometimes it's not successful. And when it's not successful, I attempt to educate the patients on the 3 P's, right? Power. First off, the uterus has to be contract strong enough to get to complete. Then the mom has to have the power to be able to push a baby out. I can't tell you how many times you're in there, you're pushing and pushing and pushing for hours upon hours and just not moving the baby. Then mom will laugh, or she'll cough, or she'll, throw up, and baby will almost projectile come out of the vagina. That's because the power of that push was so inadequate. And that does happen. Vacuums, forceps are often indicated in these types of situations. How does one improve that power? My midwives oftentimes try to attempt to train a mom on how to push, reminding them to pay attention when they're having bowel movements, those sort of different things throughout their labor, their pregnancy course, so that in labor they can initiate or fire those same muscles. Kind of muscle memory kind of thought process. I just personally feel someone who is active throughout their pregnancy is going to be have more power. Someone who's a couch potato and doesn't do very much. Someone who's and you know that person when you see them, who's never participated in any type of sports or any type of endurance activities. This is a marathon to push a baby out. So power is critically important. The next P is pelvis. Pelvis is the pelvis size adequate to allow a baby to come down? In the old days, I remember learning a little about pelvimetry, and sometimes in some of the books, even the Zhang book, which is a great tool that many of the residents now use across the country. Dr. Zhang is a professor at Maricopa County where I trained. He put together a small Bible, if you will, for obstetrics. And pelvimetry is still documented in there, where we look at the conjugate angles and the ischial spines and all these different landmarks on the pelvis to say, is the pelvis adequate? Well, we know that there's several different types of pelvises. Some pelvises are good for having babies. Some pelvises are not so good for having babies. Unfortunately, there are some individuals out there who will equate certain shapes of pelvises, aneuploid, platypoid, 2 additional ones. It's slipping my mind right now, but nonetheless, associated with race and cultures and other things like that. And I don't know that I've ever read a study that concluded that a certain race had a certain type of pelvis which would make them less adequate for having a vaginal delivery. I would say, still, nonetheless, we know when we check a cervix or we check a pelvis, we can see a sharp pubic symphysis angle or real prominent ischial spines, or just a narrow pelvis in general. These things are just critical things to keep in mind. But I do want to caution making a critical judgment about a pelvis. I had a patient who came to me many years ago, when I first started practicing, and she had a prior C-section, and she wanted a vaginal delivery, and she had in her chart, because she had seen my former partner, cephalopelvic disproportion. Okay, and that means that the head was too big to come out because the pelvis was too narrow or too small. Typically really describes the pelvis being the problem, cephalopelvic disproportion. And nonetheless, typically if you have that diagnosis, then a VBAC, a vaginal delivery, should not be successful after having had a C-section. We would think that in very similar situations, same father, same mother, the baby's not going to come out. Anyway, I counseled her, talked about the labor curve and all the different things and expectations, and she came in, she labored, and 2 steps back. Our first baby was 7 pounds, 14 ounces, and she delivered via C-section because of CPD. The second time she came in, she labored with us, not my partner at that time, and she labored for all of 4 hours. Went to complete. Pushed for less than 15 minutes and pushed out a 9-pound, 4-ounce baby. So it's not cephalopelvic disproportion there. That pelvis was adequate. That head of the baby was fine. The baby was bigger than the first baby. So I caution that diagnosis because it really is I want to say a death sentence for a lot of moms who would like to have a VBAC in the future, because when it's diagnosed and written on a piece of paper, it gives credence and power to whomever to choose that a vaginal delivery is not warranted or should not be offered to that patient. Last P is the passenger. And I think this is truly what happened with the story I just gave you, the passenger. The passenger really does play a key role in getting and having a vaginal delivery. Number one, if the passenger is 10 or to 15 pounds, that passenger is going to have a hard time passing through a normal size pelvis. Point blank, no question. That goes back to the cephalopelvic disproportion to some degree, but nonetheless, a large baby has a difficult time going through pelvis. We can make that assumption and move from there. The other aspects of the passenger are passenger's position. Passenger sometimes comes down and is asynclitic, meaning not hitting the opening quite correctly, or the passenger's OP. Again, a different type of rotation where baby's laying on its back, looking up, where baby's supposed to be looking down into the mom's sacrum, and as baby comes up, baby lifts its head and looks out into the world, ready to face the next challenge, correct? Passenger, again, plays a very huge role in coming out. The passenger could also be tied up in the nuke cord and not allowed to descend. The passenger could be having decels and not tolerating labor. I mean, again, the passenger could be IUGR, super small, and again, the placenta is old and not tolerating labor. So the passenger plays a key role in delivering. Quick story here. I had a mom who came in and she was laboring, and the baby had this huge decel for about 4 minutes or something silly like that on the monitor. And I was in the office. They called me, huge decel, Dr. Hervey, come right away. I ran over there to the bedside. The baby's heart tones were up. They were category 1 at this point in time. No further decels or anything, but there was a decel that had happened a few minutes prior. I counseled the patient. Patient was crying and said, I want a C-section. I said, I'm happy to give you a C-section. She had a vaginal delivery the first time, but I said, I'm happy to give you a C-section. She said, I don't want anything to happen to my baby. Just give me a C-section, get this baby out. As I'm sitting there consenting her, counseling her on what a primary C-section means for her future pregnancies, et cetera, et cetera. There was another quick decel on the monitor, not as long, and mom says, oh my gosh, something just happened. I feel a ton of pressure right? So prior to that, her exam was like 6 centimeters. I asked for permission to check her. She agreed. I checked her. She's complete +2. What had happened was that baby was OP for all that time. And as baby was coming down with those contractions, baby would hit its head up against the pubic symphysis, and baby, I imagine in my mind, screams on the inside, holds its breath just like those babies do when they come out. They hold their breath in defiance, and they're crying so hard, and they hold their breath. And heart tones went down because baby bradycardied in that instance. Then baby said, ouch, that hurts. I don't want to do that again. Rolled over, fell into the pelvis. She pushed 2 times and had a baby. So again, the passenger plays a key role in delivery as well. I just thought that was a nice nugget. I hope that's helpful. 3 P's in having a successful vaginal delivery: power to get to complete, power to push, pelvis size, comparison to that of the baby, its adequacy, and just be conscientious about diagnosing CPD, and then finally, passenger. Passenger plays a critical role in being able to have a successful vaginal delivery. There is a myriad of reasons why the passenger would have difficulties coming through that pelvis. Thank you.